Hi, and welcome again to Opting In for Opt-Out Screening, Understanding the Essentials of Opt-Out HIV Screening Guidelines and Confronting Barriers in Implementation. My name is Maria Kelly. I'm with the Primary Care Development Corporation, and I just want to go over a few housekeeping items. We ask that you please keep your phones on mute unless you are asking a question or reporting out. We ask that you please do not put this call on hold, or all of us will hear your hold music. If you have any questions, we do ask that you use the chat function or the question function to send those questions to us, and we'll make sure that they are addressed before the end of the webinar. If you are at an organization where you're sharing a computer and not all participants have registered, please send your contact information in the chat window so that we can follow up with you and send you a copy of the slides and the recording. And finally, today's webinar is being recorded, and we'll be sending the link to the recording after this webinar. Primary Care Development Corporation, or PCDC, was founded in 1993. We are a nonprofit organization, and we work to expand and transform primary care in underserved communities to improve health outcomes, lower healthcare costs, and reduce disparities. We have three fundamental programs here at PCDC: capital investment. So if you are a healthcare organization looking for capital funding, we can provide capital loans to healthcare organizations for capital projects. We also have our performance improvement department that does a variety of quality improvement projects and technical assistance. And then we have our policy and advocacy department where we work on helping to advocate for policy at that level. So I just want to share a little bit about our HIP and Healthcare project, and that's where the California Learning Community comes in. PCDC was funded by the CDC for a 5-year grant to provide high-impact prevention in healthcare programs. And we do this through technical assistance, which is at no cost to healthcare organizations like yourself. And we can come out to you and help you in various areas as it relates to HIV testing, high-impact HIV testing, prevention with positive, and prevention with high-risk negatives. The California Learning Community, you do not have to be a part of the California Learning Community in order to receive this free technical assistance, but the California Learning Community is designed for organizations to work together and be able to learn from one another and increase their capacity to provide services within these three areas, which are HIV testing, prevention with positives, and prevention with high-risk negatives. And one of the things that we pride ourselves on in the HIP and Healthcare Learning Community is that we try to utilize the patient-centered medical home and chronic care management strategies and principles to improve HIV prevention with healthcare organizations like yourself. So I just want to go over our schedule of events. In November, we had an in-person full-day session in Fresno, California, and today is our first webinar, which is going to be on opting in for opt-out screening. We have another webinar next month, January. The topic is to be determined. We'd love to hear your input. If there's a specific topic area that you'd like to know more about, please chat it to us. We thank you so much for your responses to the assessment that was sent out, and we will take into consideration those topic areas that you have expressed interest in. And finally, our last in-person session, our learning session number 2, will be on Friday, February 12th. It will be a full day. This is a change if you received information even as late as last week. The date was Thursday, February 11th. So I just want to make you aware of that is a change in the date. It is now going to be Friday, February 12th, and you'll receive correspondence to confirm that in the following weeks. And so we're going to move on now to the main event. opting in for opt-out screening. And I'll let Stefan Perez introduce himself. Thank you.
Thank you so much, Maria, and thank you to all of you who are on the webinar today. It's really great to be able to be here with all of you in the California learning community, and I'd like to thank Primary Care Development Corporation and the CDC for their ongoing work in HIV prevention and capacity building. As Maria said, my name is Stefan Perez, and I am a nurse practitioner and a nurse who's been working in the field of HIV for about 10 years. I am a native Californian, actually, and worked in HIV care out there in the Bay Area for quite a few years before moving out to the East Coast. So I'm really excited to be able to be working with some wonderful people that I know are out there working in the HIV community in California. Today, we're going to be talking about something that's a key concept in HIV prevention and testing, but one that's a little bit old, but I think still innovative, and we'll talk a little bit about why, and that's opt-out screening. And we'll talk about some of the essential key components of opt-out HIV screening, a little bit about the guidelines, and talk about why, even though these guidelines came out from the CDC in 2006, some areas and some health systems still have a little bit of trouble understanding what the concept really means, what it doesn't mean, and how to implement it. All right, we always have to start with our learning objectives for today. So after this presentation is over, I hope that we'll be able to define the basic concept of opt-out screening. We'll describe the rationale behind opt-out HIV screening. We'll talk about, and you'll be able to describe 3 components of opt-out HIV screening from the most recent CDC guidelines, and then identify 4 key considerations when implementing or improving your opt-out screening in primary care settings. So I always like to start with a picture like this and ask participants who is at risk for HIV. And I just want you to kind of take a couple of seconds, look at this picture, and think in your mind, if you were working in the HIV care setting or in the primary care setting and any one of these people could walk into your clinic, who would you guess by looking at this picture might be at risk for or even HIV positive? And the reality is that we really aren't able to tell very well who's at risk for HIV. And when I say we, I talk about our healthcare provider community in general. And there's a lot of literature out there that supports that. And it doesn't mean that we're bad providers, and it doesn't mean that we're not that we don't have good relationships with our patients. But it means that our ideas and the reality of who's at risk for HIV infection in this country has really shifted since the beginning of the epidemic. We'll talk a little bit more about that, and the implications that that has on our traditional idea of risk-based screening. So today, according to the latest statistics from the CDC, about 1 in 8 people with HIV don't know they have it. And these numbers are actually improved. You know, people who worked in the field for a while remember for a long time the statistic out there was about 1 in 5, or about 18 to 20% of people who were HIV positive didn't know they had the infection. So this number is improving, but the reality is that when we talk about specific populations and really drill down into the epidemiology, we see that that number shifts pretty dramatically when we look at certain populations who are at high risk. Particularly our young population, ages 13 to 24, in that demographic, about half of that demographic living with HIV don't know that they have the infection. So it's a pretty significant difference from 1 in 8 to 1 in 2. Similarly, when we talk about gay or bisexual men or men who have sex with men, that statistic goes up to about 1 in 5 who are living with HIV don't know they have it. So the reason that I like to show these graphics and talk a little bit about drilling down into the data a little bit more is because when we look at the broader picture of the HIV epidemic in the United States, some of these certain risk groups kind of get smoothed out in the data, so we don't really see the increased risk that certain risk groups have and the increased importance of screening and testing in these groups. Now, I'm sure all of you who are participating today are familiar with the HIV Care Continuum. This is not as new of a concept anymore. This was originally published by Dr. Gardner in 2011 and was a big big deal and really a very interesting way, an innovative way of looking at the epidemic of HIV in the United States, and spawned many similar continuums across many different countries, many localities, and even for other diseases like hepatitis C. But this is the HIV Care Continuum in the United States using 2011 data from the Medical Monitoring Project. And as you can see here, you can see that that number has shifted from 1 in 5 in terms of diagnosed, so down to about only 1 in 8 not knowing their infection. So there have been some gains in terms of people being diagnosed who are living with HIV. But then you can see that if we go down the continuum all the way to virologic suppression, which is people living with HIV whose viral loads are undetectable because of treatment, we see that that number is still only 30% of the people living with HIV in the United States are virologically suppressed. And so obviously these numbers shift depending on localities, again, when you really drill down into different demographics and localities in the data. But this is still a very, very huge disease process that's affecting people living in the United States. A little bit more about some of the epidemiology, and this is really kind of driving why screening is still important. And it really just talks about the relevance of HIV infection in the United States, and that it hasn't gone away, and that it doesn't look like it's going away, unfortunately, anytime soon. And while you can see here that there is an uptick from 2011 to 2012, really when you compare 2008 to 2012, the data shows that there certainly hasn't been a decrease, but that there hasn't really been a huge increase in new infections. However, the data has remained pretty stable in terms of the number of new infections from 2008 to 2012. So despite wonderful prevention efforts and the hard work of community-based organizations and advocacy organizations and government organizations, new infections are still occurring and transmission is still happening in the United States. And we see that again looking at 2012 data in those specific risk categories. So particularly men who have sex with men, that risk category, transmission category continues to increase from 2008 to 2012. And I put this slide up because I really wanted to draw your attention again to that very young demographic, that demographic of 13 to 24 that's seen an increased rate of new infections, and 25 to 34 years that's seen an increased rate of new infections, but also our 45 to 54-year-olds seeing an increased rate of new infections. And that's really key because, you know, when we talk about who we're going to be testing, we might not necessarily always be thinking about testing for HIV in some of these populations. And that's why screening becomes a very important tool when thinking about HIV infection in our populations, particularly in primary care. And we know from research that once people become aware of their HIV status, particularly if they're HIV positive, the prevalence of high-risk behavior is reduced substantially. And we actually, and of course now, we have some really great tools out there, particularly with pre-exposure prophylaxis. So if someone is, you know, in a relationship and they find out they're HIV positive, we can put their partner on pre-exposure prophylaxis. We have some really great tools out there to prevent HIV infection, but we have to also be able to diagnose HIV infection as well. And that kind of leads us to screening. And screening is not a new concept. Screening for health issues is not something new, but it's something that's really readily applied to HIV, and that's because HIV generally meets the accepted criteria to justify routine screening, and some of that criteria from the World Health Organization. Again, this is from 1968, so this is not, you know, new information. But screening is applicable for serious health issues that can be detected before symptoms develop. So certainly HIV falls into that category. And when we have treatment that's more beneficial when symptoms when begun before symptoms develop, certainly we have seen that evolution of beginning antiretroviral therapy now when people test positive. You know, before it was wait till 250 or 200, then 350, then 500, and now we've finally arrived after years of research at this conclusion that we should be treating people as soon as they're diagnosed. And we know we now have reliable and inexpensive and acceptable screening tests. We've seen some amazing technological advances from tests that, took a week or 2 weeks to get results back to now tests that can be done in a minute in terms of rapid tests. And then costs of the screening are reasonable in relation to the anticipated benefits, right? So a $25 screening test for HIV is going to be, far outweigh any negative consequences of not being able to diagnose HIV infection until late in the disease course. So again, I want you to kind of think a little bit about what are some of the current processes for conducting HIV screening in the clinical care setting, and maybe think a little bit about what's going on in your care settings. So, suppose a patient walks into your clinic this afternoon, and think a little bit about some of the rationale that you would apply to potentially screening that patient. So do providers in your clinic provide screening for all people who fall under current screening guidelines, but they conduct a comprehensive sexual health history, provide that 30 minutes of pre-test counseling, and then conduct the test? Are we going to ask the patient if they think they should have an HIV test, and if they say no, are we going to tell them that they're wrong and why they're wrong? Should we tell the patient that you really don't think that they need an HIV test, but I can order one if they really want it, but I don't think that you need it? Or should we use the opt-out screening method in patients in whom HIV infection is suspected as part of the differential diagnosis? We'll talk a little bit about why that's probably not the best time to use opt-out screening. Or should we screen patients according to the current guidelines and using the opt-out screening method? And usually the simplest answer is the right one, right? And that's going to be E in this case. And, I'm sure many of you remember, depending on how long you've worked in HIV or how long you've been active in the HIV community, that screening guidelines or HIV testing used to be very different prior to 2006. And in 2006, the CDC pretty drastically revised their guidelines to reflect a more opt-out screening and a more screening-friendly approach to HIV testing. Remember, the previous CDC recommendations only advised testing people who were perceived to be at risk and asking patients if they wanted an HIV test. There was a separate consent that was often required, had a lot of extensive pre-counseling, a lot of extensive post-counseling, and it was, varied, of course, depending on test result, but even negative test results required quite a bit of counseling. And in 2006, the CDC revised those guidelines to say that really we should improve our HIV testing by implementing a screening approach to anyone aged 13 to 64 for opt-out. And, obviously we have to include a right to refusal depending on, or for notification of the HIV screening, but we should be offering it to all eligible patients and at every medical contact. So in any medical setting or any healthcare setting, not necessarily limited to specialized testing centers, not necessarily limited to infectious disease workups or hospitalizations. These should be offered to anywhere that persons engage the medical community. And no separate consent form is required. General consent for care is sufficient. Pre-counseling was very limited and very limited pre-counseling was required for routine performance of HIV tests. But post-counseling and education and linkage to care is still going to be extensive. We don't want to lose that component for our patients. But for negative test results, the post-test counseling is going to be very, very much more abbreviated than what we used to do prior to these guidelines. So this was a pretty big jump, and I think that in a lot of ways this was very difficult for people to get on board with, and we'll talk a little bit about some of the controversy. So why HIV screening? Why are we moving away from risk-based testing? Well, it's pretty simple. We know that these recommendations can improve detection and can increase timely treatment, and that big public health push, which is to reduce transmission. More than, and this data is a little bit older. We talked earlier that it's now about 1 in 8 instead of 1 in 5. But now we have, we're seeing a different shift in the epidemiology of HIV infection, and there's much more of an identified epidemic in heterosexuals, in women, in adolescents, and in people over the age of 50, as opposed to what the epidemic looked like very early on in terms of those classic risk categories. Earlier detection of HIV infection is going to be really important, particularly in the earlier course of the disease where people are most infectious, particularly in their first few weeks after infection. So, repeat screening, depending on very high-risk behavior, might be warranted. Anyone who's sexually active is really going to be at risk for HIV infection, and that sort of takes a little bit of a deviation from thinking about our most high-risk patients. So, providers are not always that great at figuring out who exactly is quote-unquote high-risk in their patient population. So it's really going to be very important that we sort of take the approach that most people who walk through our clinic doors are going to have some risk for HIV infection, either currently or previously, and that's why implementing the screening population is really important. And we know that patients don't always disclose or might not even be aware of their risk. We've seen that 39% from research, that 39% of men who had sex with men within the past year have not disclosed that to their healthcare provider. So that's still a pretty big, stigma and confidentiality and privacy is still a very big issue for a lot of people when they go to visit their healthcare provider. We'll talk a little bit about how attitudes around HIV testing has changed, but for many people, this is still a big issue of stigma and privacy. And again, 51% of rapid test people in the emergency department who test positive from rapid tests in screening had no identified risk. And identified risk is usually typically disclosed risk. So people certainly say, I don't know how I might have gotten this, but definitely, we don't always consider, people don't always consider some of their risk behaviors to be risk behaviors, as we would classically define them as healthcare providers. And in looking at where patients are getting tested, and again, this data is a little bit older, from 2006, but it's still pretty significant. A lot of people are getting tested in their private doctor or their personal healthcare provider's office. So whether that be a community health center, whether that be a private provider, whether that be a hospital-based outpatient practice, people are getting diagnosed outside of the sort of traditional HIV testing centers and HIV testing facilities where we would not necessarily think about we would not necessarily think about people not being diagnosed. So we talked a little bit about some of the general reasons why we should be screening. We talked a little bit about what screening is. Let's talk a little bit about this concept of opt-out screening, because there's some, I think, misconceptions around opt-out screening, and there's some things that need to be kind of clarified from time to time. So opt-out screening is very simple, and this is taken directly from the CDC HIV testing guidelines. And it's performing HIV screening after notifying the patient that A, the test will be performed, and B, that the patient may elect to decline or defer testing. Assent is inferred unless the patient declines testing. So when the provider is offering the diabetes screening, the kidney disease screening, the hepatitis screening, the thyroid screening, they're also offering alongside of that the HIV screening. And if at that point the patient is allowed to decline, as they would be able to decline any of those screening tests, but if the patient doesn't say anything, or the patient agrees, nods their head, whatever, then, or says nothing, again, then assent is inferred. And it's really key to remember that this policy is fully supported by the revised recommendations for HIV testing. And this is straight from the Centers for Disease Control. Some of the key components of opt-out screening include that it's part of the other health screenings that might be done during a patient's evaluation. So again, like we talked about, just as a provider or a nurse or somebody would order battery of routine screening tests for a first visit or for an annual visit, this is something that would be added on to that. There's not a required separate consent. The pre-test risk assessment and counseling are not recommended, and they're not required. Education does need to be provided to the patient, either orally or in writing, but this is in general for any type of lab test that should be done, right? We should be educating our patient for any test that we're running in terms of why we're running it and what potential results could mean, when we're going to be giving them those results, how they'll be delivered, all of those things. And the patient always reserves the right to decline, but it's really important that if the patient does decline the HIV test or any screening test, that needs to be documented in the medical record, and the reason should also be documented in the medical record. Perhaps the patient is in a monogamous relationship and they were tested 6 months ago or a year. That needs to be documented in terms of why that patient is declining, because it may not be applicable to screen that patient again. So what opt-out testing is not, and I think that this is really important for people to understand, opt-out testing is not a secret. So we're not in the back secretly, typing into Epic that our order sets for HIV testing. We need to be telling our patients, so this is not screening without telling the patients. It's not mandatory. We're not saying that if you come in here for a visit, I'm giving you a test, an HIV test. I'm screening you for HIV. This is not a mandatory thing. These are guidelines, right? Guidelines are meant to guide us. They're not mandatory. And it's not asking patients if they want an HIV test. Remember, that was one of the examples we talked about earlier. We don't, it's not necessarily always a bad thing to ask them if they want it. Sometimes our patients are afraid to tell us that they want it, but we get the sense that that might be why they're here. So bringing it up that way might work, but it's not, screening is not routinely asking patients if they want an HIV test. And it's not to be used as a diagnostic testing strategy, and this is really key. Remember the difference between screening and testing. Testing is really looking for a specific diagnosis, a specific disease process. So if we have a patient that comes in and they think it looks like they might have acute HIV infection, or they've had a very high-risk encounter, and we suspect HIV as part of the differential diagnosis, opt-out screening is not necessarily a concept that we need to be employing in that situation. And that's because if we truly do think that HIV is considered as a diagnosis for something, for potential presentation that we're seeing in the clinic, it's really important that we give them some information about why we're running this test. It's really important to give them some information about what test results could potentially mean, and give them a little bit more information than what would normally be given in terms of opt-out testing. And I think, that makes sense for any type of focused testing or diagnostic. We want to be giving our patient a little bit more information about what to expect in the results. I also want to say that it doesn't mean that the provider has no say over what they can or can't order. The same screening guidelines apply. These are at the provider's discretion. So again, these are not mandates. This is not, mandatory. The provider can choose to defer, just as the patient can choose to defer. But these are guidelines that are meant to give us guidance and to sort of help make sure that our patients get the highest level of care. So why this push for opt-out screening? And it's just as we talked about, it's because providers may not necessarily be accurate in assessing the risk or risk behaviors associated with HIV infection. And we've seen this in the literature. It's very clear in the literature that that providers do have some trouble in assessing risk or risk behavior, particularly with HIV infection. Opt-out screening has been shown to increase testing uptake in certain populations. We've seen that definitely in pregnant populations. We've seen it in emergency departments. It may decrease some of the stigma or anxiety around HIV testing. It sort of normalizes testing. So if this is your clinic's policy that, every first-time patient gets tested for HIV unless they have a documented, result that they provide in their medical records, then it sort of eliminates that feeling of being singled out in terms of being tested for HIV. It eliminates some of that stigma. It's just part of routine care that we give to everybody. Counseling The counseling effect on preventing the transmission of HIV or acquiring HIV between partners has had some mixed results in the literature. So there are some studies that show that it is somewhat effective. Other studies show that it's not as effective. So as a result of that these sort of mixed findings, that's why that was sort of moved out of the screening guidelines, and particularly for opt-out screening. And the majority of people feel that HIV testing should actually be a part of regular services and that it's not different from other tests. So even though stigma is still alive, there are certain groups out there who, and people out there who just feel like it's just part of the regular battery of tests that I get. And, while it may not necessarily be quite the same as screening for diabetes, it is certainly just as important and just another part of the routine care that they deserve. The other piece that I want to put out there is that, what the providers say is actually really important, and patients really listen to what their providers say. And this happens to be a study looking specifically at physicians, but I would, as a nurse practitioner myself, I would be willing to say that our patients really do respect what we have to say. Any provider in the healthcare system, be it any kind of healthcare worker, nurse, physician, NP, PA, our patients come to us for guidance and recommendations. And we have some studies to show that. But the flip side of that is that, without that recommendation, sometimes care can get a little bit lost. And in fact, we have some studies that show that sometimes we're not as good about suggesting an HIV test or offering the HIV test or conducting the HIV test. So it's really kind of a key piece that opt-out screening can actually improve sort of the provider comfort level around offering an HIV test or conducting HIV screening. It sort of routinizes that HIV screening. And I think that that's sort of supported by many of the provider organizations in the United States. And because of that, because of the knowledge that providers can really drive this screening tactic, that a lot of the provider organizations have really endorsed HIV screening and the screening guidelines presented by the CDC. And this is just a sample of some of the professional organizations who have supported this. When we talk about HIV testing attitudes and thinking about whether the perception of HIV or whether HIV testing actually leads to any kind of stigma. This is kind of an interesting study done by the Kaiser Family Foundation, and it looks at survey data taken from 2006 and then from 2009 around HIV testing, and so a difference of 3 years. And they asked quite a few interesting questions around stigma in HIV testing, and this one asks, if you were to be tested for HIV, do you think it would make people think less of you, think more of you, or would it make no difference in how people think of you? And in terms of the people who said that it would make no difference in how people would think of them, you can see that more people started in 2009 than in 2006 said that it probably wouldn't make any difference in how people think of you. And you can see that the proportion of people who thought it would make others think less of them decreased. So, it's kind of interesting to sort of see these changing attitudes in the country around HIV screening. And around, I think it's a proxy for HIV disease in general, although certainly there's still an immense stigma out there. And that stigma is certainly a huge barrier to testing and treatment. But I think, some of what we have seen is supportive in that some of these attitudes around testing in particular are changing, which is a good thing, because then that sort of aids in having the conversation with our patients. And this is a simple, this is another look at people who have been tested in the past for HIV and the perception of testing-related stigma and reported testing rates, which I think is really interesting. So looking at testing, whether or not they've been tested in the past 12 months. And you can see that for those who say people would think more of them if they found out they were tested, those people tend to have been tested, there tend to have been a higher percentage of people who were ever tested than people who were not tested. And then you can see that all the way at the bottom, those who say that people would think less of them if they found out they were tested, that percentage tends to be the lower percentage of people who are tested. So in general, we can say that the less stigma that's out there, the sort of higher the rates of testing, or the more acceptability of HIV testing. And I think that that's really key, because that's sort of from the patient side of things, that sort of tells us that our patients might actually be a little bit more willing to accept some of this HIV testing, some of this opt-out HIV testing strategy, if we implement it in our healthcare settings. But just like any kind of guideline around healthcare in the United States, there are obvious controversies, and I think there are some serious controversies around opt-out HIV screening. And there's some ethical issues around consent and stigma, and because stigma, as I said before, is still very much a valid concern, and that stigma is not the same across all groups. So while we may see these better trends when it comes to stigma in the United States, that certainly might not be the trend in your community that you're serving. It might not be the trend in certain demographics of the United States, in certain vulnerable populations. So stigma is still very much a big issue, and it's something that we need to be very sensitive to as healthcare providers. Special populations might be a very significant consideration for opt-out screening. So vulnerable populations in particular, we want to think about offering screening, or how we offer our screening to people who might not have insurance, to people who might not readily have access to care, to other types of vulnerable populations. We want to make sure, first and foremost, and just for any test that we offer our patients, we have to be ready to accept the diagnosis that test might confer. So if there's a possibility that one of these HIV screening tests might come back positive, we have to be ready to provide them with the highest level of care that we can. So we can't do these opt-out screening programs willy-nilly without any type of support system and linkage to care system. And that's not just for HIV, that's for any type of disease. Consent is going to be approached in many different ways, but it should always be in the interest of preserving the patient-provider relationship. So if you have a patient who you have a good relationship with, and you know that they might not be, that this type of opt-out screening might not necessarily be the best way to approach HIV testing, well, then that's going to be at your discretion to work with your patient if you feel that they should be screened. So again, this is a broad guideline. It's a great guideline. It works very well, but it's not going to be applicable to every single patient-provider relationship. And it must also take into account any kind of legal or administrative requirements. So, while there's a really great website, HIV law website, that you can just Google HIV law, and it will give you a compendium of all 50 states, all their laws around HIV testing and consent. Most, if not all, of the states now have acclimated to this opt-out screening and guidance, but there might be some certain legal issues that I might see in Pennsylvania that are different from the ones in California. Certainly, there might be different legal issues, or there might be different administrative regulations in my health system versus your health system. So all of those things need to be taken into account. Okay. There's a few additional controversies. We talked a little bit about the appropriateness of testing in certain settings. These guidelines that we've been talking about are supportive of HIV testing in pretty much all medical or clinical settings. But again, we have to have the appropriate infrastructure in terms of linkage to care to support whatever diagnosis might come out of this screening. And there is some loss of counseling or potential opportunity for patient education, but I want to caution around that controversy, because I want to remind everybody that just because we're doing opt-out screening doesn't mean that we can't do additional education for some of our patients. If we feel that someone is at high risk and we're continuing to do screening for them, that doesn't mean that we can't also do patient education, or we can't refer them to somebody who can do additional patient education for them. This is not meant as a restrictive. This is just meant to improve some of the screening techniques around HIV screening. All right, so now we'll talk a little bit about some of the key considerations for implementing opt-out screening, then I really want you to think about what's going on in your health center or in your facility around HIV screening, what you're doing, what you want to be doing, and how you've been trying to improve it, how you've been trying to change it. And we'll talk a little bit more in depth about some ways to approach developing an opt-out screening program. The first thing is, you always have to start by understanding your patient population. So we always want to think about, who are we providing care for? What is our community? That's why we're there, right? We're working in our communities. We're there to provide care for our community. So what's going on in that community, we have to understand. The guidelines say that if the prevalence is less than 1 in 1,000, you don't need to conduct routine screening. And I've traveled all over the country. I've worked with many different health centers. I have never set foot in a health center that's told me, we conducted a pilot study, we screened 1,000 people, and we have no we had no HIV positive test results. So I want to caution systems to not jump on that statistic. Certainly, there's local epidemiological data that might support this, but it's really hard to know your population unless you are doing the screening day in and day out. So yes, this is in the guidelines, but like I said, I've never seen a clinic that has presented a really beautiful study saying, here, we screened 1,000 people, here's documentation of all their test results, none were lost to follow-up, and we're certain about the prevalence. If that's done, great. More power to you. You can, consider a change in your HIV screening, but, that's sort of a baseline statistic. But I think even more important is thinking about who are the special, or who are the populations in your community, and are there any special considerations that you need to think about for those populations? So do you know some of the higher risk populations in your community? Is there, are there populations that might be at lower risk or at unknown risk? Have you done, assessment of who's coming into your clinic? Do you have any special populations or populations that might be particularly vulnerable? These would be the undocumented populations that you're serving, maternity patients, adolescent patients, uninsured patients, anybody who might fall into a little bit more of a vulnerable category, who might need closer intervention, who might have a more difficult linkage to care if they do test positive. Those are going to be really key considerations when starting an HIV screening program. Are there any interventions in place to educate your high-risk patients? So what are some of the things that you have on hand to educate your high-risk patients and your staff with? These are very key considerations. And is there stigma in the population? That's really important, knowing some of the ideologies of your community, knowing whether or not stigma might be an issue. And this really leads into privacy issues that might arise in your population. I've been to so many wonderful health centers, and one of the, I think, most wonderful thing about community health centers is that people from the community work in these health centers, and that can be wonderful, and it's often such a great aspect of the community health center, but it can also pose some privacy issues, particularly around stigmatizing diseases or health issues. So it's really important to think about, is there a privacy concern within the health center that might serve as a barrier to implementing a screening program? You have to understand your resources, and there are so many wonderful resources out there, but you have to know what's available in your clinic, or excuse me, in your community around HIV care, HIV services, and HIV education. Is there a likelihood or a possibility that a positive test result might turn up? Yes, that's a likelihood, that's a possibility in any community in the United States. So we have to think about what's available for our patients and where can we link them for care and treatment. AIDS service organizations, local providers, pharmacies, case management services, any other support services. These are going to be really key questions to ask of your administration, to ask of your staff. So we have to have those in place before we start really doing this ramped up opt-out screening. And what are the staffing resources that are going to be needed, either on-site or within your area? Some areas don't have a lot of HIV services readily available to them. So it's important to not only look at staffing resources and needs within your center, but also potentially in your community as well. And there's wonderful programs from the CDC, from HRSA, our AIDS Education and Training Centers. All of these are ready, willing, and able to assist you with staff training, education, linking to community resources. There's so much out there that's available. It's just a matter of identifying it and building these relationships. One of the things that I always talk about with leadership at these health centers are there some internal barriers to opt-out screening? Is there any staff discomfort or stigma that's there? Because there very well might be. You know, HIV is still, as I said, a stigmatized disease. Many providers, you know, particularly if you were trained, you know, even 10 years ago, many providers didn't receive a lot of HIV training either in medical school or nursing school or pharmacy school. They just simply didn't receive it. So if you don't care for people living with HIV every day, it can still be a daunting disease and a very complicated one. So there might be a lot of existing and underlying discomfort around working with this population. So it's really important to assess that, and it's nothing negative about your team. It's just really important to assess that. And in one of the ways to do that, I think it's really important to identify somebody on your team who's going to take leadership around building these opt-out screening programs, and somebody who might actually be ready and willing to deliver some of the positive test results or offer some of the education to patients. If you don't have that within the organization, then it's really important to link to services in the community. And these linkages can be done with a memorandum of understanding, provision of written materials, plans for follow-up, or a clinical consultation for your providers. Next, we have to look at the feasibility of opt-out testing in your setting. So what is this going to look like day to day for my staff? What new systems do we have to have in place? Is our electronic medical record ready to handle? Do we need to get lab orders in there? Do we need to build lab sets? What needs to happen to make sure that the day-to-day process is okay and ready to go? What screening test are we going to use? Are we going to be using serum tests, rapid tests? How are we going to order those? Who's going to be responsible for that? Who's going to check inventory? You know, make sure the tests are ready and okay to go. Who knows how to conduct the tests? How are we going to train? All of these things need to be considered. Thinking about clinical workflows for testing, if we're doing rapid testing, are our providers going to do the test? Is it going to be the medical assistant, the nurse? You know, how are we going to actually conduct the tests? Documentation, how are we going to document refusals, positive test results? How are we going to give those results to the patient? Who's going to deliver the results? And then just as important as issues around reimbursement and coding, making sure that your ICD-10 code, that you understand the ICD-10 coding component around this. Screening tests versus diagnostic testing is going to be really important in terms of coding. Workflow for a positive test result is really key. Like I said, any health center potentially could have a positive test result. So what are we going to do in that case of a positive test result, particularly if we're doing rapid testing? Who's going to be giving that result? What are the next steps of the patient? How is that going to interrupt workflow? All of those things need to be considered, hopefully before when and if you get a positive test result. One of the things that I really like to talk about is quality improvement methodology, and it's not a new concept, and most of you out there have probably had some training in quality improvement. But you know, treating this as any other new initiative or intervention for your patients is going to be really important. It's important to always give an outlet for your staff to share feedback. So they're going to be the ones on the front line. They're going to be the ones who are understanding what works and what doesn't. It's going to be really key that you give them an opportunity to give feedback around that. It also improves their buy-in. If they feel like they have an opportunity to talk about what's not working or what's working well, that's really key to getting their buy-in. Continually evaluating policies and procedures, so using that feedback to kind of shift and adjust some of the policies and procedures is going to be really important. You should always have a way to track data around what you're doing in terms of HIV testing and your results. You know, if this is an important initiative in your clinic or in your health system or in your health center, you're going to want to provide feedback to staff and to other stakeholders around how this is working. Are you seeing an improvement in testing rates? Are you seeing a drop in testing rates? What's happening as a result of your initiatives? Listen to your patients' responses. If you're getting an overwhelming response, either positive or negative, that's really important to listen to. So if a lot of patients are saying, why is everybody asking me about HIV testing? What's going on? This feels odd. This feels weird. Why are you targeting me? That's an important opportunity for re-education about what your HIV screening program is all about. And then it's important to secure the buy-in of both administrative and clinical leadership. So, you always have to have the buy-in of the executive team, because ultimately they're going to be the ones who are offering their support. They might be the ones who are getting on board in terms of looking for funding mechanisms for this if you are seeking out additional funding. So it's important to really look at the administrative and clinical leadership and get some buy-in and also some feedback from them. And then finally, you want to understand and identify some methods for sustainability. So ongoing evaluation of what's working and what's not. We talked a little bit about that already, but that's really key to making sure that your screening program continues to function well. Make the process as easy on the clinical workflow as possible. So there's nothing harder than telling your clinical team that we're going to implement a new program, and it's probably going to add a good 30 minutes to your work time per day, or a good hour to your work time per day. Forget about it. It has to be part of routine care. It has to meld into the clinical workflow as much as possible. Sometimes making a big deal out of a new policy and procedure invites controversy. I have had some CEOs and some clinical directors who just, we arrive to do all this great capacity building, and they just say, oh, we just wrote a policy and procedure and told everybody at the last staff meeting that this is happening. And the staff did it. These were like magical health centers, right? So, but those kinds of things work really, sometimes that type of strategy works really well, particularly if you have the infrastructure to do it. Now, sometimes these implementing a screening program or an opt-out screening program takes a lot of work. It is a big deal for a health center to do this. You have to have new technology come in, all of these things, so it's not as easy to kind of slip it in. But if you have the capacity to do it, it might be an easier strategy to just implement it and just do it. Listen to staff concerns. Be prepared to educate and train on the importance of this type of a testing strategy. That's really, really key. You do want to listen to what your staff has to say, because how else are you going to assess where they might need the education, where you might have some training gaps, where you're going to be able to use education to change a little bit about thinking and behavior. Anytime you can automate processes are really great for sustainability. So anytime you can build these processes into your electronic health record and make it a default type of screening, it's going to make lives much more easier for you as you work towards a sustainable model. Confirming linkages in community partner and making sure that those lines of communications stay open. So, once you have the MOUs up and running, setting up a quarterly call, or, depending on how often you're referring patients over there, it might be important to set up a monthly call or a quarterly call just to kind of check in, see, learn anything new about the community partner. The community partner has an opportunity to see how your screening program is going. All of these things are going to be really important. And then you want to identify a champion. So a lot of places have project managers, a lot of places have, nurse leaders or nursing directors, and sometimes they become the champion. But I invite you to take a look and see if there's anybody in your health system that has some HIV training, that maybe has an interest in HIV care or screening, or is familiar with testing, or maybe it's had a testing background, maybe before they became a clinician or a social worker or something. They've worked in the field before, and they're interested in sort of getting back into it. Anyone who has an interest in seeing this type of a project succeed is going to be really key for sustainability. So with that, I just want to leave you with a few final thoughts. And that's really that opt-out screening is fully supported by the guidelines. And as we saw, it's supported by a lot of professional organizations. There's still a lot of controversy out there. but there are a lot of benefits to this type of a screening program, and it can be successfully integrated into a lot of different types of care settings. Remember, we don't want to step on the patient or provider discretion. Our patients are still in the driver's seat. They have the opportunity to decline a screening test, and our providers still have the discretion to not offer a screening test if they feel that it's not appropriate at that time. So we want to make sure that our patients and providers and their relationship are still driving the care. But just like with any other test, we want to follow the guidelines as much as possible. And just because this is opt-out and screening, we don't want to offer this in isolation from counseling. Education and linkage to care, when appropriate, are going to be key to making sure that our patients get the highest level and the best care that we can offer them. So with that, every time I do a talk like this, I feel like, hopefully it's lighting a little rocket and you guys are just ready to go, but I know that there's a lot of things that need to get in place and probably a lot of discussions that need to be had. But I want to say thank you for listening to this presentation today. And I hope that if you're doing HIV screening and you're doing opt-out testing, that it's going well and that you can identify some areas where you might be able to improve. Or if you're thinking about implementing an opt-out screening program, that this is giving you some thoughtful ideas about where to go from here. So with that, I'm going to turn it over back to Maria and Kimmy and just say thank you again.
Thank you, Stefan. And I want to just open the floor up for questions. We have a few minutes left. If you have any questions, please, you can chat them into the chat function or raise your hand and we'll unmute your lines. Okay, while we're waiting for that, we'll give it another 30 seconds or so. I just want to remind you that we do have free capacity building services available through the HIP and Healthcare Project in the California Learning Community. So please reach out to us if you're interested in capacity building services, if you're interested in learning what capacity building services might directly entail, and we can follow up with you and help you with that. So capacity building services could be technical assistance on site, it could be virtual. It really depends on what your concerns are. And so it doesn't appear that we have any questions at this time. So what I would like to do is thank you all very much for your participation and your time today. We will be sending out the slides and the recording to everyone who registered for the webinar today. And if you have, again, you can always follow up if you have any questions. We have one question. Okay, so I'm going to, we're addressing that question and then I will sign off now. I hope you guys have a great rest of your day and look out in your emails for the recording. Thank you.